Mr. Flores.
Thank you, Mr. Chairman. Dr. Emmendorf, thank you for joining us again today.
Congressman.
I'd like to shift gears just a minute in the early part of my question to talk about the CBO cost estimate for H.R. 3230 having to do with the VA healthcare issues that are facing the nation today. In your estimate, in a nutshell, you said that it would cost, or not you, the CBO said that it would cost about $22 billion in fiscal 16 for H.R. 3230. And that if the bill was fully implemented by FY16, it would be about $38 billion. The question that arises is if current cost today in the VA for 6.5 million enrollees are about $37 billion, how can we have a more than doubling in cost when we just have a slight potential increase in the number of people that would be used? And so I'll break the question into two parts. And again, this is about H.R. 3230, and we'll talk about the Senate bill next. So for those that are currently enrolled in veterans health care, how does the CBO estimate the bill would affect the health care utilization by veterans?
So, Congressman, the detailed estimate we provided is for the bill as passed by the Senate. They adopted the House number, so the estimate says H.R. 3230, but the version is passed by the Senate.
Let's talk about the Senate bill then.
And I think the key issue here that I think surprised me when I learned it and surprises some people is that for the veterans enrolled in VA healthcare today, they get only about a third of their care through the VA system.
Correct.
They get 2/3 other ways. And what this legislation would do is to enable veterans who couldn't get into a veterans facility to have the care they're getting through their current doctors outside of VA, paid for by VA. And because the veterans system has very low copayments relative to most private health insurance, there's a financial incentive for those veterans to have more of the health care they're already getting through their doctors, to keep getting through those same doctors, but to have VA pay so they save on their copayments. So we think there would be an increase of about, in terms of the share of health care spending for the veterans who are currently enrolled, they would go from having about a third of their care paid for through VA to having 55% paid for through VA.
Mm-hmm. I mean,
and then there are also some new people we think who don't get health care through VA at all, who would start to get health care through VA, but they're a much smaller part of the...
That's the second part of my question. But what's the empirical evidence that CBO was able to rely upon to jump from that 30, it's actually 30% in your report, to 55%? So almost double. How does the CBO develop that number? Did you have any empirical evidence? Was it a swag? What? Help me out here.
So there are... we have empirical evidence about the difference in copayments, what people end up paying out of pocket in VA versus other places. And then there's a body of evidence about how people respond to the cost of health care and their decision about where to get the care, or in this case, who to get to pay for the care. But I'm not aware of evidence that's directly about a change in the opportunities for veterans enrolled in VA health care. This is a new approach, really. Mm-hmm. So there's a great deal of uncertainty around our estimate, and I wouldn't pretend otherwise. But there is basic evidence in general about how people respond to changes in the cost of care that we drew on.
But it does sound like there's substantial uncertainty in the estimates, just because we don't really know. We don't have an actual fact pattern that we can rely upon historically.
We don't have evidence that's as close to this particular question as we wish we had, Congressman.
Right. Okay.
Yes.
So the second part of my question is, what's the impact on health care utilization by veterans who are eligible for veterans health care, but who are not currently enrolled in veterans in VA health care?
So, Congressman, we think that only a small percentage, about 15 to 20% of those who are not enrolled in VA health care would choose to enroll under this program eventually, and we don't get to that 15 to 20% within the couple of years that the program is scheduled to be in.
As you know, we're working with the CBO to try to get the numbers flanged up, because it's hard for many of us to think that it's credible that our costs are going to double when we're really not talking about a very big expansion in the population or the utilization of health care. I've got a question for you for the record, since we're running out of time. One of the things that came out earlier was the impact of immigration reform. And I think your language was, it increases the size of the labor force. And so since we're talking about the size of the labor force, as it was said earlier in the conversation today in this hearing, the labor force participation rate is at a long-term low. And based on some of the analytics I've seen, The difference between the labor force participation rate today and the labor force participation rate, if on a historical trend, expressed in a number of workers, is about 4.7 million workers. So I'd like supplementally for you to answer, what's the impact on GDP if we put those Americans to work, if we had those policies, and the impact on the deficit? Thank you very much. I yield back.
Thank you.